I am Dr. Carrie Diulus. I am an orthopedic spine surgeon at the Crystal Clinic in Akron, Ohio.
Todd Wetzel, I'm past president of NASS and orthopedic spine surgeon in New York.
Dr. Mark Cuccuzella, I'm a professor of family medicine, West Virginia University in Ranson, West Virginia.
Thank you and welcome. Today's topic is really how to optimize a patient for surgery. This is a problem for all of us who perform surgery. Oftentimes we have to operate on people who aren't optimized, but when we have the opportunity, given so many of the risk factors that our patients seem to have, what we'd like to do is discuss our experiences in doing this and really propose a way that this can be integrated into your practices. Clearly, we've all identified the risk factors, A1C, dementia, various other things. And there are various tools that have been used to help measure these things, such as the Strong for Surgery Index, the kind of post hoc indicators, NSQIP. But the question is really, if we get started with these patients to optimize them, when should we do that? What are your thoughts on that, Mark?
Yeah, so Todd, we work closely with the orthopedic department when you're looking 3 to 6 months out for joint replacement. So that's the ideal time. And we have a BMI cutoff of 45 to be able to operate. So several who are looking at those procedures have BMIs higher than that. Most of them also have diabetes, other comorbidities, polypharmacy, don't exercise. So that's actually the optimum time if you can get them to go, right? That's hard because people are busy and they feel like, oh, this is just one more thing. But our surgeons really encourage them to go and make it and we really make it an empathetic and positive encounter where we look at their lifestyles and try to make some simple changes. Mostly it's with the diet. Most people don't understand what they're eating. And nutrition and walking, just walking will help their muscle strength. So many people are protein insufficient if they're preparing for a major surgery, so making sure they understand that it's okay and safe to eat protein. And then we also identify some of the major comorbidities that put them at higher risk and try to control those. That would be, renal disease, cardiovascular disease, any kind of heart failure. But polypharmacy is a big one. And that's a time we can go through like the Beers list. That's just a common list of medications. If they're on more than 5 or 6 chronic medications, their likelihood of falling between the time I see them and the surgery is pretty high.
Yeah.
So it's really looking at the basics and trying to nudge them, into a better state of health and confidence that they can sustain a major surgery.
Well, this sounds like what you've developed at your institution is really kind of a comprehensive co-management strategy to get people optimized for surgery. Is that fair to say? Yes,
and it's really enlightening that our surgeons are looking at this. We have some really forward-thinking surgeons that they know the outcome of a joint replacement is highly dependent on the strength of the patient, but they're busy, they don't have time, so that's it's enjoyable if we can work together with our colleagues for a better outcome.
Yeah. Do you work with other specialists, Carrie, or do you tend to run this program, this optimization mostly on your own?
So in the area that I'm at, I don't have the resources at this time for a program like that I can refer patients to. There are some national programs that are becoming available that are location independent, but for now I've been doing it on my own, and it's actually a point where we have more power sometimes to motivate patients to make real change with impending surgery coming up than seeing their primary care doctor. So often the primary care doctors will say, well, I've been trying to optimize them for 10 years, I've got them as good as they're going to be. Whereas when we talk about having a surgery coming up and saying, for me the cutoff would be a BMI over 40, an A1C over 7, and I have a very open, honest conversation with the patients about, we want to partner together on this surgery and have you have an outcome that you're happy with. And these are the things that we can do in general: dietary changes, looking at vitamin D status, looking at albumin. Those are some very simple, concrete things. So A1C, vitamin D, and albumin levels I check on all surgical patients. And every single one of those is modifiable, including their BMI. And some patients need more help, but we've gotten to the point where I've been doing it with my team for so long. We have a dietary approach that we give them. My nurse goes through it with them. So it's very brief in the amount of time I have to spend. And we've seen patients where I can take them from an A1C of 9 down to an A1C of 6.5 in 6 weeks, which is about how far I'm scheduled out for surgery.
Yeah, that sounds like a wonderful way to have incorporated that in your particular practice. But you know, and I'm sure we've all had this experience, and you mentioned it, a patient who the primary care says it's as good as they're going to get. And it's almost like they give up, the patient gives up, and they sit there with an A1C of 11, and they don't get their surgery, or they do. So how do you deal with that kind of a mindset?
I think, like Dr. Diulus was saying, you empower them and make them really the center of the team, and you deal with them in their social context. Smoking is huge in my state,
right,
you know, the data is pretty firm that 6 to 8 weeks, if you can get people off tobacco, even 4 weeks, your surgical outcomes are better. Alcohol's another one too. So the diet, but these are some other things that I think are really important. And if you see patients willing to getting up and walking, because we know early ambulation is one of the primary factors of who gets out of the hospital and who doesn't need to go to a rehab facility. So they just kind of vision what their recovery wants to be like. And again, that they need to understand they own it, but not in a negative way. But I think, like all of us, if we have, if we understand it too, if it's not simple, clear, and understandable what they need to do, if it's a list of 20 things, they won't do any. But if you give them maybe 1 or 2 for their key drivers, and then they'll see some results, especially with blood sugar. If they're eating a standard American diet, you can make their blood sugar better in 12 hours by changing what they eat, and then they're very curious about that.
Yeah, I'm sorry.
I was going to say to Dr. Cuccuzella's point that empowering the patient is powerful. Most of them come to us and they have a sense of shame around their weight and their A1C and their inability. And the single most powerful thing that I do and have learned to do is to help to remove that shame and say this is not a moral failing on your part. This is, dietary advice that we've given in the past was not effective for you because it's not effective for a lot of people. So let's come up with a plan that you can do and that you can see success. And then, if you allow them to see success even within the first couple of, 12 hours with blood sugar or the first couple of weeks with weight, it is amazing how much they are now engaged in this process, and it's powerful to watch as someone who's partnering with them.
Yeah, I think that's a great point. What about the role of a kind of a psychological screen in this, like the start back tool to look for so-called, yellow flags or red flags? I mean, how does that play into your optimization strategy?
The psychological stuff for sure can be an important factor. In some patients, it's more obvious than others. I do have some psychotherapists that are local in the group. That is where I reach out to get help because, in the time that I have, addressing those things are harder. So I do send patients for CBT therapy, the cognitive behavioral therapy. And that can be a significant factor in their recovery from surgery. And there are times when the therapist tells me this person's not ready for surgery yet, and we need to, do some more work because surgery in itself can be a trauma. And so we need to have people who are, partnering with those patients who need that extra support.
Yeah, and that's wonderful, I think, particularly in the case where the surgeon's receptive to those things, because it's not so much the old, captain of the ship. It really is a team effort, and part of that team is the patient himself to enlist them. Well, as we wrap up here, what do you think are, say, the handful of most important things to get under control before surgery? Say, let's recommend 5 things that we ought to get under control or check. What do you think, Mark?
Yeah, one I forgot to mention, and it affects the psychology too, if someone is not sleeping. So I would guess, because they come in and I've never had a negative test for sleep apnea for people that have come to me pre-op with BMIs of 45.
That's a very good point.
If we get them far enough ahead of the surgery to identify the sleep apnea, I think a lot of stuff sorts itself out once they start sleeping. So just another one to think about for people that have high BMIs, large neck circumference. Other than that, this is old school stuff. I remember reading somewhere where in the old days the surgeons would go around and look at the legs of the patient and be able to determine who was a good surgical candidate. The ones who had muscle mass on the legs, they're good for surgery. The ones that didn't, they're not going to do too well. And you don't need an electronic checklist for that. Can they get up and out of bed?
Okay.
That's a powerful thing, and that's avoiding what's called sarcopenia, which is muscle wasting.
Right.
Especially as we get older, and that ties into the nutrition. Exercise is king, nutrition is queen, and together you have a kingdom, so to speak, and then get a little bit of sleep on top of that. And social support. So, if patients are living by themselves and lonely and don't have social support or some kind of purpose for wanting, and that comes down to why do they want the surgery if it's an elective surgery. Quite often patients aren't informed enough that this is an option. Really, this is a serious surgery. Do you really want to go through this?
Right.
And maybe that would be like the first conversation, because they're all pushed down the medicalization pathway for more procedures, but maybe that isn't even the right thing at the time.
Okay, so BMI, sleep apnea,
sugar,
and check
sleep
their
apnea.
legs.
Look at their legs for
Okay.
some muscle.
All right. What would you add to the short list, Carrie?
Dietary things
Right,
are
okay.
important. So BMI and A1C, blood sugar control. We're not withholding procedures from patients if we help them optimize for those. And I think that's important distinction. So, sleep for sure is something that's important, and their ability and willingness to be active in some way. And if they're not, then the question is why? What is their barrier to wanting to ride on an exercise bike? Or, so I will let my patients know that we will have an exercise program that you'll engage in after surgery, so that before surgery, they're aware of that being part of the surgical process, and making all of it not just the surgery, but that the surgery event includes all of these preoperative optimization things, and then postoperative things, so that they look at the entire package rather than just what happens when they show up on Tuesday morning on the 4th of the month.
Yeah, I think that's an important point, and maybe to kind of put it in a bit of a nutshell, at least for the surgeons, we were always taught that 90% of surgical success is preoperative planning, and that was always kind of technically emphasized during our residency. But this is such an important component of preoperative planning that this is probably at least as much responsible for postoperative success as anything we would do technically. So hopefully this has been helpful, a good way to look at your patients and efficiently optimize their care.